I am Maxime Legados, rheumatologist in Paris, and currently attending the EULAR 2022 meeting in Copenhagen, where I have presented a study trying to understand the concept of residual pain. So what is residual pain? In daily practice, we are more frequently nowadays facing the following problem. We have a patient with plenty of swollen joints, a high CRP. We initiate a treatment, whatever the treatment is, and then you see the patient 3 months later. The doctor is very happy because no more swollen joint, no more CRP, but the patient is still complaining. And this pain is called residual pain. And the current question nowadays with the JAK inhibitors is whether JAK inhibitors have on the top of their anti-inflammatory effect a specific analgesic effect, which might be more relevant in comparison to the anti-TNF. So we took the opportunity to collaborate with Pfizer to revisit the Pfizer database with 7 placebo-controlled trials in rheumatoid arthritis, 2 in psoriatic arthritis, and also using adalimumab. And we evaluate the level of pain in the very small subgroup of patients with a complete abrogation of inflammation after 3 months of therapy, either treating with tofacitinib, adalimumab, or placebo. So, of course, it's a small percentage of patients. You see, there's a very hard endpoint. No swollen joint, normal CRP at 3 months. And then we check the level of pain. And the level of pain was higher in the subgroup of patients who received the placebo, despite the fact that they had a complete abrogation of inflammation, than in the patient receiving either adalimumab or JAK inhibitor, tofacitinib here. So we conclude that potentially, on the top of the anti-inflammatory effect, we can observe an analgesic effect. But here, we failed to demonstrate a difference between a JAK inhibitor, tofa here, versus an anti-TNF, adalimumab. But my feeling is that this field of research, the concept of residual pain, is very interesting because very relevant for our clinicians.